the MAIA trial was in transplant non-eligible patients and was testing the benefit of adding the CD38-directed antibody Daratumumab to Lenalidomide Dexamethasone. So it's a late phase 3 study of Daratumumab Lendex versus Lendex for frontline therapy. And what's been presented at the European Myeloma Network meeting is actually the Frailty subgroup. Now, the IMWG Frailty score used age, comorbidity, and 2 functional assessments, the ADL and IADL, which are time-consuming, often difficult and sometimes subjective in their measurements, but more importantly, you can't apply these retrospectively to trial cohorts. And Thierry Facon and colleagues developed a modified version of IMWG where they tested actually the EQ5D module or WHO performance score and found that both were equally as valid. So you can use age, comorbidities and performance score to define people as being fit or unfit. And this frailty subgroup analysis in MAIA is using that same strategy, being able to delineate patients who are fit or frail, basically. And the bottom line is that what this showed for, particularly for the PFS, is that for patients who are non-frail, then again, Dara to Lendex shows a superior PFS. But equally in patients who are frail, there is an uplift in the PFS significantly for those who receive Dara Lendex. Now, what's interesting for me is that if you look at the non-frail patients who got Lendex, they actually don't do quite as well, albeit it's subtle, as the frail getting Dara Lendex. So Dara Lendex does better if you're frail than Lendex if you're non-frail. Now, the difference there is subtle and is not going to be statistically significant, but it does indicate that you can deliver this triplet regimen to frail patients, and they will, A, do better than the doublet in the frail patient group, and B, they actually are performing slightly better than the doublet in the non-frail group. So it's very interesting data. It's a post-trial subgroup analysis, so you can't be dogmatic about the results, but what I think they do is show a nice trend that's worthy of pursuing, because there is this feeling that for frail patients, then only doublets are the way to go. When in actual fact, what this shows is that actually that's not necessarily the case, and it gives very, very good groundwork to start designing some prospective clinical trials where you can actually incorporate that into your thinking.